welcome to all to our ongoing series of Friday morning webinars. You can always know that a Friday morning at 9 o'clock, we're going to be here with somebody really interesting to talk to. This conversation today is with my longtime friend and colleague, Steve Heilig. I will introduce him briefly here, or perhaps not so briefly, because the introduction takes a couple of minutes because it's really interesting. Steve was educated at 5 University of California campuses in public health, epidemiology, medical ethics, addiction, economics, and environmental sciences. And his work includes positions at the San Francisco Medical Society, California Pacific Medical Center, University of California, San Francisco, and as co-editor of the Cambridge Quarterly on healthcare ethics. He has been part of the Commonweal team for 25 years, working on many projects at Commonweal, including co-founding the Collaborative on Health and the Environment, and as a host of many conversations at the New School at Commonweal. He's authored many medical policies at state and national levels for the San Francisco Medical Society and the California Medical Society and the American Medical Association. And he was a Robert Wood Johnson Fellow on Drug Abuses issues. He received the California Medical Association's annual award for service to medicine and public health. His work on legalizing choice at the beginning and end of life landed on the front page of the New York Times twice. And he has authored hundreds of articles and book reviews for many publications. He served as an editor of Surfing Medicine and the indomitable Bolinas Hearsay News, and as the head master of ceremonies at the Sierra Nevada World Music Festival. His undergraduate honors thesis was about the ever-growing threat of pandemics, and thus in these times, his interests have come full circle. Steve Heilig, welcome to the learning community in the New School.
Thank you, Michael. Should I welcome you to the New School too? I mean, we are the 2 primary hosts for New School Talks, so it's kind of interesting. This is like dueling hosts here.
We've never done it together before.
Right. But Michael asked me to do this, and I, of course, wouldn't say no. So you want me to just go ahead, Michael?
Yeah, please.
Okay. So thank you, everybody, for signing in and joining us today. I know there's many old friends and colleagues here, so I'm kind of intimidated by it because I'm not going to be able to pull too many quick ones on anybody here. But we're obviously in a very extreme and interesting time for humanity and healthcare and maybe even civilization in some strange way. So Michael wanted me to talk a little bit about why me, how I got here. So here, maybe we could show the first image there. There it is. So I found this old document, and I was a Southern California beach kid, not much of a scholar or a student, but very interested in a lot of things. And as mentioned, I jumped around from various UC campuses in the 1970s going to school, ended up with a few degrees in a bunch of different topics. But what really got me interested in this particular arena was this thesis that I did. And this was at UC Santa Barbara. I wanted to stay there the rest of my life because I lived in a beautiful beach house in a beautiful place, but you can't really do that. So there was a famous professor there named Garrett Hardin, infamous to some people. His one famous paper, most famous paper, was called Tragedy of the Commons, published in 1968 in Science, the journal. And I convinced him to let me stay an extra year and do a thesis. And at the same time, I was working at the Student Health Center, where I was doing triage of patients to where they were supposed to go and as a lab tech, and seeing a lot of drug resistance, antibiotic resistant infections there. And I started reading about it and came up with this idea for a thesis about what will happen if these bacteria become resistant to everything we have in terms of antibiotics. The antibiotic era only started in the 1940s, and it's, I'd say without question, the biggest single development in human medicine in terms of the impact on people's health, and has become threatened by the continuing Darwinian evolution of the bugs. So this one, you can kind of see the image there. It's a needle bending off of the arm. And I wrote this, it's almost 100 pages long, and it became published and talked about a lot. And it's what really got me into graduate school, because I wasn't that great of a student as an undergrad. I had too many majors and was too distracted. So I went on to study a lot more about this, traveled the world a bit after that, doing some work, but mostly just spending any money I'd saved. Came back to San Francisco, 1983, so 37 years ago. And what was happening then was the initial explosion of a new epidemic or pandemic that later became identified as HIV or AIDS. At the time, when it was first starting, we didn't really know what it was. There wasn't a name for it, didn't know how it was transmitted. And it was a very heady time centered here in San Francisco, where there was a lot of fear about how is it transmitted, who's at risk, is there going to be any treatment? Because at the time it seemed to be, and was for quite some years, 100% fatal. So that's kind of the context for this. And Michael said, well, why don't we talk about any flashbacks you're having to HIV era and what you think is going on here? So I've stayed here in San Francisco all this time and worked on all the issues that Michael mentioned there. And when this hit, starting in January, the COVID bug, it changed the entire focus of everybody's work here, because we were in an emergency. And I remember very clearly we went at a meeting where our health officer, who is the #1 public health doctor in any area in San Francisco, his name's Tomas Aragon, wonderful guy, highly qualified, and just a great guy. And he said, I'm going to have to shut basically the city down, and I'm going to need your support. He was talking to a large group of physicians. And that's basically what happened. They say no webinar is complete without a cat. So this is Charlie, sorry. And since then, we've been dealing with this, both in terms of the science and the medical response and the economic response as well. So we're in, as I say, an intense time. So let me do a little history here. And Kira, maybe we could see the next image. So here's a little handy chart about the history of pandemics. I'll start with a quote, though, first. Joshua Lederberg, who was a renowned biologist, the youngest, I believe, ever to get a Nobel Prize in medicine at age 33. And his famous quote is, "The single biggest threat to man's continuous dominance on the planet is the virus," unquote. And there's a little interesting thing to say in there. Note the term dominance. So I'll come back to that. So Homo sapiens, that's us, has exploded in its numbers, our numbers, in the past 200 years. Went from 1 billion 200 years ago to edging up to 8 billion now, 200 years later. And this means that there are more and more people spread all over the planet in more and more crowded conditions. And our impact has gotten to the point where the new term that's being used in terms of geologic eras is the Anthropocene, which means that humans are the dominant impact on our planet in many different ways. But if you look at this chart here, you'll see that one of the dominant influences on us has been these pandemics through the years. Now, these are fuzzy numbers, of course, going way back in terms of how many were impacted, how many died. But you can see, as far as back we're measuring, this goes back to 1 AD, basically. Every once in a while, there's something very serious happening at various degrees. One of the interesting things about this, if you look back to the first half of it at least or more, they're basically or mostly all bacterial infections. And then the more recent ones, including the current one and including HIV, are viral. It's an interesting dynamic that's happening. We're seeing more and more viral breakouts, epidemics, and pandemics in this modern era. And part of this, well, let's say a little more about the history. If you
Steve, let me interrupt you there for a minute.
Yes.
Are you going to say why we're getting more viral as opposed to bacterial?
Well, yeah. So
Okay.
I mean, there's all kinds of ideas about that, but that's what I'm getting to is that the spread is much more rapid now in terms of crowding and travel that gets them around sooner. They also, HIV in particular, and now this new COVID, have long latent periods at times where you can get, I mean, with HIV, it was decades where you can be infected and spread the infection without being sick yourself. Now, with HIV, it could be a decade or more. With this, it's more like a matter of a week or two. But that's a crucial element in these. Most bacterial infections, you get to know that you've got them fairly rapidly. Now, the other things that's not in here, I don't believe, is the endemic infections that we've lived with. Malaria, for example. Some historians of these diseases say that malaria has killed more humans than any other factor throughout our history. It's still killing 500,000 or more a year, and depends on where you live, et cetera. So some of them come and go. An outbreak like Ebola, which is very quickly lethal, tends to be localized, and unless people are really spreading around quickly, an outbreak of that will die out because people who have it all die, and it can be controlled, perhaps, and hopefully easier than some of these others. You look at this chart too, some people will say that these outbreaks have killed more humans than any wars. The most recent big example being the 100 years ago Spanish influenza outbreak, which happened right towards the tail end of World War I. And some or most historians say that it actually killed a lot more people than the war did. As humans spread around the world too, they brought these various infections with them. So the same dynamic. If you look at the New World, North and South America, consensus is that the infections that the colonialists brought killed many more people than any of their actual actions in terms of war and so forth, as bad as those were. So clearly these bugs and viruses are extreme influences on our history. And that's not going to go away, as Dr. Letterberg said and as many others have said. There's been warnings, extreme warnings for many years that we are vulnerable due to travel and other crowding our modern agricultural system and decimation of rainforests and all kinds of things. And now, in particular, climate change, which is lending itself to travel of these infections as well. So the ones that we're talking about, the current one is what is known as a zoonosis, zoo being the first part of that word, which means comes from animals. And that is a dominant type of infection that's happening now as well, too. There have been the more recent ones, such as SARS and things like that, have been traced back to animals. It's still fuzzy exactly where this one came from. There's a lot of competing theories about, the wet markets in China, et cetera, and what kind of animal. We don't need to get into that. It's actually become politicized, of course, like everything else here. But the hallmark of it, the really important part, is that it has a asymptomatic transmission period in that you can get infected yourself and not have any symptoms. And it could be pre-symptomatic as well. Even if you're going to get sick, you're still transmitting. And asymptomatic means you never really get seriously ill, but you're still transmitting the virus. And then the question of its lethality, how dangerous it is. If you look at the first, it's very interesting. In January was one of the first alarms raised about this in an international sense. a Harvard epidemiologist wrote a post looking at the bug itself and how lethal it might be. And the title of his post was, quote, "Holy Mother of God," unquote. Now, he seems to have overestimated the lethality of it as over 3% for all infections. But the message is that this was a very dangerous virus that was going to be spreading very fast. Turned out he was right, at least on that. So UCSF, which is right over there, has been hosting really great medical grand rounds for the last couple of months, where they spend a couple hours with great experts on all the aspects of COVID. And I have, they're don't miss for me. I've been watching them every Thursday. And they tend to bring up speakers on a lot of different topics, but there's at least 4 that are really crucial to at least mention in terms of what the research they're doing and in terms of what's going on and trying to improve things. The first one is the testing issue, of course. And you've seen probably a lot about this in terms of how to use it, what it's valuable for. Unfortunately, and I'm maybe a little more skeptical than some, but judging from yesterday's talks about this too at UCSF, the tests are still not so great overall. You can, depending on what tests you can use, and one of the problems is that they were flooding the market. All these commercial companies flooded the markets with 40, 50, 60 different testing products with highly variable accuracy. You can get either or both false positives, which means you get a test that says you've been infected but you're not, or a false negative, which is the opposite. It means that you are infected and the test says you're not. So that's a big problem, of course. But going beyond that, the question is, what do you do with the test results? Now, for public health tracking, epidemiology, and contact tracing, the kind of things that we do, these will be very important, assuming some accuracy in them. For individuals, they don't tell you that much in terms of what you can do, because there is not effective treatment per se. There's not an indication on how, if you have been infected, what your chances of getting seriously ill are. And the big question here is about immunity, is if you've had it, how immune will you be after that? Yesterday's talk, at least at UCSF, at least had more optimism that being infected will confer immunity, because that's been a real question. Not all bugs or infections confer immunity. And the speakers yesterday said, we're pretty sure it will, at least for a year or two. So that's going to be very important because the antibody tests, one of the types of tests that are out there, that's what they're measuring, is if you have developed antibodies that will help you keep you from not getting infected. Treatment issues are very rough. They had 2 speakers on yesterday, docs who went from UCSF to New York. This is where we get into the tale of 2 cities. So New York, I'm sure you've all heard, was hit very hard and still is hit very hard by this. Probably a lot of reasons for that. It got there early, but also anybody who's been to Manhattan knows how crowded it is on the streets, on the subways, in the buildings. And it really got around there, and they did not shut things down quite as soon as many people believe they should have. So the hospitals there, some of them became overwhelmed, and they put out a call for volunteers and for help and for equipment, which they didn't have. These 2 physicians that came back and reported yesterday were very committed, even noble about it. They said, it was horrible, but this is what we signed up to do. But one of them said, what I learned was great humility, because we really couldn't do much of anything. We could try to comfort people and try to keep them breathing as long as we could, but you could tell, and these were ICU physicians who are used to people in extreme negative health status. So it's inspiring to hear them, but also daunting to see what has happened there in New York City. Now, out here on this coast, we did shut down early, as I mentioned. People have been monitoring the reports from physicians and particularly hospitalizations, which is the measure of severe disease, of course. And there's a weekly call with all the hospitals that I'm on as well, where everybody reports in what's going on, and really leveled out a few weeks ago in terms of people coming to the hospitals. Everybody was ramping up for a real flood of patients, including even putting tents out front of the hospital to try to triage people so you weren't taking in too many and try to get them elsewhere. And then a topic that Michael and I think we'll talk about, there was a rapid trying to develop policy and guidelines for what do we do if we have to ration care, particularly ventilators and ICU care. Fortunately, none of that has been needed, and most of the hospitals have remained at about half of their normal overall census, and that's because all the other procedures have been shut down. And then a gradual rise, but then a leveling off of COVID cases. And other than certain instances and certain times, there hasn't been an overflow in the ICUs, and there hasn't been a need for all of this ramping up. We were hoping to do the surge, it was called. And people have actually been sent home that were brought in to prepare for this. So it's a very interesting thing. And we think this is, we don't know what would have happened otherwise, but I think it's pretty clear that this is so far a success story overall. Now, if you look at specific populations, it's a little more complicated and frightening, because in populations such as some of the long-term care facilities, retirement homes or retirement hospitals even, jails, homeless population, and some of the more crowded communities, such as in the Mission, you're still seeing a lot more cases. And this is part of this whole picture is, since the virus seems to hit much harder in older people, and it's seeming to be now, we're seeing a higher lethality or at least severity in ethnic communities as well. Particularly, it's measured so far what it's looking like both Asian and Latino communities. So that's something to really consider. And then you may have seen recent reports too about Native American communities, including the reservations, being hit very hard by this. So we're really at the beginning of that and responding to all of that. One of the other big problems of this brings up another quote, which the original quote was, "In war, the first casualty is truth." Well, it seems to be true in epidemics as well. What we've been seeing here is a tremendous amount of misinformation. A lot of it, hopefully most of it, inadvertent. People are just scrambling to find out what's going on in terms of treating themselves, but also how it spread, where it came from, but also a tremendous amount of conspiracy theories and things like that. Now, I don't want to get too much into it, but a lot of this is, if not originating, is spread by certain politicians. Probably don't need to be named right now. We may get into that. It's a tragic time where we need leadership more than any other time. We don't really have it at the federal level. The Centers for Disease Control would be like the lead agency on this. They've been sidelined, decimated, et cetera, et cetera. So what we're seeing is even what the World Health Organization just called a tsunami of hatred, of bias against particularly Asians who were blamed for this. And that's another bit of a flashback to the HIV era. When that first came out and were first exploding, people were blaming anybody they could think of, but it was particularly the gay community, Haitians for a while, and drug users for spreading this. And we're in this period of time where that seems to be endemic, which is the term for when an infection becomes just a permanent or at least long-term part of the community. So there's a lot of questions about how well we can talk about more when Michael and I talk about masks, how to use them, and what's useful, and so forth. But I'll wind up with just we could Kira, you want to show the next one? We could have before. I think everybody's seen it. There's the virus. It's almost pretty, isn't it? It's a strange thing. So I think you've seen that before. And the next one, please. So this is the topic that I'll end with, is speculating a lot on what this is going to mean for humanity and our planet. I confess to some discomfort with this because what I've seen a lot of, as much as I like it, is a lot of speculation about how the end result of this pandemic is going to be very positive for humanity. That's hopeful. It's possible in the long run in some ways. But most of what I've seen, and you may have seen, there's a beautiful video out of a guy that came from England, I think, explaining to his young child about what happened and how we came through this and how it was a net positive. And it's really great to watch. It's moving, but it kind of ignores the great carnage and suffering that it takes to get there, if that's where we're going. So I was trying to think about what are the silver linings, if we have them, out of this. And the one that is being mentioned the most is the ecological one. It's fascinating to see, with climate change being the biggest single threat to humanity right now, and the rest of the species as well, is the significant decline in CO2, particularly in China, from shutting down the economy, basically. And we'll see much more about what happens from the United States as well. So somewhere between 7 and 10% decline just in the first few months. It's an amazing decline that is actually remarkably similar to what people are recommending, what needs to happen for us to arrest the climate catastrophe. Now, the big question, of course, is that going to be sustainable once the economies start opening up again, assuming they do? So that's one possible positive outcome. Another one is related to, I think, other species in a sense. Obviously, they'll be profoundly impacted if we are able to arrest climate, but also just the idea of these markets that have been identified as basically a starting point for a lot of viruses. Those are being looked at now very carefully and even shut down. They're called wet markets mainly because there's so much ice there to keep the animals and fish and everything cool. But these are breeding grounds for all kinds of pathogens. And they're also horrible places for the living animals that are there. So as an animal lover, I see there's a possible positive there, and it may extend to slaughterhouses and markets for meat and animals around the world, including in our own country. You may see an increase in vegetarianism, for example. The other thing that's interesting, just on a side note to the animals, is the adoption of pets, of animals from shelters, has skyrocketed, where people want companions at home and everything. So that's a good thing too. More from the professional field, public health is hopefully going to be seen as crucial. The whole history of public health is that it's the poor stepchild of medicine. And there was a great piece by Laurie Garrett, the famous healthcare journalist, in the New York Times recently, an op-ed. And she talked about going to Harvard and seeing the medical center, which is this big, gleaming, beautiful palace of science and medicine, and then going out to the School of Public Health, which is a dump. And I laughed out loud when I read that because that was exactly, I was going to go there. I went there to check it out way back then. And the School of Public Health out on Huntington Avenue was just, it was gloomy and decrepit almost. So I saw that as a reflection of, we focus very much on cure and medicine, which is a great thing, but prevention in public health has always been shortchanged. And hopefully that will get some attention and perhaps change. Within medicine itself, there's been a movement for at least a decade or more for palliative care, which is taking care of people when you cannot necessarily cure them, but you want to minimize suffering and do your best for them. And that's the kind of model that is for COVID right now. There's a lot of people in medicine learning how to do some forms of palliative care now because of this infection, because in the extremes, when they're in the ICUs, et cetera, they can't do much else, as was mentioned earlier by the physicians who came back from New York. So this may push that along too. Science itself is exploding in terms of this responding to this epidemic. There have already been 30,000 published papers on COVID in the first 3 months of this year. It's astonishing, really. And the identification of the virus so quickly is a big contrast to what happened with HIV, where it took a long time to figure out exactly what that agent was. This time it's moving much faster. Whether it moves fast enough to get treatment and a vaccine is still to be seen. Those are very complicated tasks. And a vaccine is, of course, the gold standard, getting a working vaccine. But the consensus so far is that's going to take a fair amount of time, could be a couple of years, I think, which would be nice, actually. It would be faster than most. But maybe, who knows, they'll make some breakthroughs and get there sooner. The interesting thing, too, is that we're having perhaps overall, that's what this image is, a reprioritization of what is essential. That's a word that's being thrown around. Essential businesses, but essential people, essential professions, healthcare people, of course, but a lot of others. We're seeing an appreciation for people who produce and deliver food. One of the great ironies right now, at least in California, I don't know if it's broader, is that our farm workers have been deemed essential. Now, many of you know they have also for many years been deemed illegal, et cetera, et cetera. And I think it's quite ironic that all of a sudden people are realizing, we really need these people to provide a service. And other just frontline providers of all kinds of services really are being seen as more important now. So myself, I try to contribute how I can. I was able to acquire 15,000 masks because PPE, or personal protective equipment for clinicians, has been in great shortage. Some of that is due to bad planning. Some of that seems to be bad policy from the federal level on down. But I've been distributing these out of my garage to any clinicians that need them. And they are extremely grateful to be able to get these without having to wait for for indefinite periods and not able to get them. A doctor from one of our large hospitals who wasn't able to get any broke down crying in my driveway recently, saying, "You have no idea how important and how grateful we are for this." So that feels good. Other things I recommend to people, if you're looking for some way to help, the biggest focus that I've had in terms of just giving is to food banks, et cetera, because there's a risk of there's enough food out there, and there always has been in ways, but when you shut down restaurants and hotels and everything, you end up with surpluses, actually, but it's getting it to people who really need it is the big issue. So food banks, wherever you are very crucial. I recommend supporting them if you can. They always have been, but even more so now. If you can be a blood donor or a blood product donor, do that as well. The blood banks have seen a decline in some ways due to fear of going there. But one of the things that the researchers are really looking at is actually using blood products, particularly plasma, from people who have been infected as a treatment. So that's always a good thing to do anyway, of course. But again, we are seeing that it is more important than ever. Did I have one more image there, Kira? Yeah, so this is actually just down the hill from where I sit right now in the Haight-Ashbury. This is a young doc going to work up at UCSF with one of the boarded up stores. The graffiti there, which says, "We will survive, we will get by," is actually quoting from the Grateful Dead. It was their one hit, Touch of Grey. So it's not surprising that this appears in the Haight-Ashbury, but there is this hopeful message. And I think we're going to have an endemic bug here for a long time. It's going to depend a lot on much better leadership. We could say perhaps, judging from political trends right now, we may get a change in leadership at the end of this year, in part due to this pandemic and the lack of good response to it. So there's a couple more touchy topics that Michael, I know, wants to talk about, and we can talk about, but I'm going to end there with the lecture part of it, and then we can talk a bit, Michael, you and I believe, and then later on we'll open it up to others. So thank you all very much.
Thank you, Steve, so much. That's a wonderful introduction. I'm just going to read a few of the comments in the chat. From Shelley Rodriguez, "My first day working for San Francisco Medical Society, November 1984, included a board of directors meeting where Merv Silverman announced he was closing the bathhouses in San Francisco. What an amazing introduction to medical association and physician public health leadership." Brian Baird said, can you comment on the experience in Sweden, whether that model would work in the US? Catherine Dodd said, my concern about the picture is that it's a man who is pressing the reset. It's time for women, the mothers, and the healers to reset. And then Robert Gould, our friend and colleague, wrote, an unfortunate consequence beyond the racism, et cetera, mentioned by Steve, by Trump administration demonization of China, is the negative impact in developing the global collaboration needed for dealing with global warming. Moving in the opposite direction is the use of this crisis to bolster confrontation through increasing military nuclear budgets and programs, as recently published in the New York Times.
I should say Dr. Gould has been president of Physicians for Social Responsibility, PSR. He's an old friend and colleague and a very committed advocate for public health and so forth.
Joan Hall writes, Costa Rica is doing a lot of research in the use of plasma. The same group here that is famous for developing antivenous is doing this work. Recovered COVID patients are donating plasma, and they'll be using this as a treatment beginning in June. So those are just some of the comments. But
well, let me just say, I like Catherine Dodd's comment. There's actually been the observation that the nations that have responded most forcefully and successfully so far are all, or at least mostly, led by women.
Absolutely.
New Zealand, et cetera. So I think that's true. The Sweden issue is a really interesting one and very divisive. They have basically done a much less extreme shutdown with the idea that they can get herd immunity to this, which means you have at least a critical number, and it's anywhere 80, 90% of people that are immune. Basically, it's a big gamble they're taking. And they feel confident to take that partly because Sweden has a trust in their government, in healthcare systems, national healthcare, and a lot more in place that they can respond to this. But even in Sweden, it's very controversial because it seems to be that their numbers are going up much faster than in other places. And the poorer people in Sweden, which they do have, are inordinately impacted. And I can just tell you, I have some dear old friends who are both physicians trained in Sweden. And they say this is something they have had to agree to not talk about at the dinner table because one of them supports it and one of them is absolutely opposed. So that's something that remains to be played out, how that's going to work.
So, Steve, let me ask you this genuine question without valence. If it's true that this virus will ultimately reach 70% or so of the population, if it's true that social isolation and so forth is a way of flattening the curve to enable hospitals and so forth to be able to cope with it, then it seems to me that in addition to the Sweden question, we have to ask what the price the global South and poor people everywhere are paying to enable those who are able to socially isolate to do so. Because, as we all know, COVID has resulted in a global recession, may well be a global depression. And for hundreds of millions of people, this means getting food, having work, is just a profoundly serious issue. We hear reflections of this in the United States. So my question is, if it's going to spread, if it's endemic, if it's going to spread, I understand the argument that, well, maybe in the next few years we'll get a vaccine, maybe in the next few years we'll get better treatment. But we both know that not only is it going to be a couple of years before we get a vaccine at best, but it will take a lot more time to amp that up so that everybody can actually get the vaccine. So you are an ethicist. What are the ethics of trying to close down the global economy, fractured and terrible as it is for the environment and everything else, at enormous cost to poor people everywhere, and the global south in particular, in the service of what medical ethics tells us to do, as opposed to global public health ethics, of trying to save everyone we can who is able to do social distancing and so forth.
Simple question, right?
Right.
It's that's the big question. So any policy in any realm is a trade-off, basically, is a calculation of risk and benefits. And this one is extremely difficult because it's very hard. I mean, one of the dictums in public health is that if you succeed, nothing happens, right? So it's very hard to measure what would have happened otherwise. And I mean, I agree that the both in terms of the economics, but even in terms of health impacts. If you look at what happened in 2008 with the crash, you had a real spike in health problems, including suicide, due to the economic impact of that. And we're likely to see that to some degree here as well. So the perspective that you look at it through depends. I mean, it determines a lot on what you think is the right thing to do. And so I agree that the people who are healthcare professionals, public health professionals, are very clearly focused on trying to minimize healthcare harms. You talk about the global south and otherwise, they are just seeing that you don't even know what's happening there, but it looks like they're going to have, in a lot of places, Africa, South America, Asia, tremendous carnage from this this virus. I keep calling it a bug, that's bacteria. But I don't have an answer for that. I think what we need to do and what people are leaning towards now and trying to do is to minimize in reopening a bit, to minimize the impacts of the infection itself spreading more and the economics. So it's partial and careful reopening. What I fear and what people in healthcare fear, it's less the HIV model it is the Spanish influenza model. If you look at what happened then, if you look at where we are right now, they had the outbreak, they did a lot of shutdown, they had the mandatory masks and things like that. They reopened in the summer, and the impact in the fall was much bigger than it was in the spring. They had an explosion then. That's where most of the people died and were infected. We could very much have that same scenario. So, it's a tough one, and I'm glad I'm not the mayor or something like that of cities like here where you're trying to walk that fine line to find a middle path where you can minimize infections and hopefully open up the economy more. I have friends here who are now, hand to mouth, unemployed, et cetera, et cetera. The stores are shut and all of that. And it's tough. I agree. I don't have an answer for that, but I think there is a middle path that we need to be on, and we can do. It's nothing's going to be no harm, but it's going to be minimized. Other countries I can't speak to. I think that they're earlier on this, and it's going, as with HIV, for example, it's going to be really rough there.
Have any of the lectures that you've listened to or anything that you've heard gotten more precise on genetic variants in susceptibility? Because you read that people really haven't figured out why some countries seem to be getting hit much harder than others. And you talked about the Latino, Asian American, Native American, and you didn't mention, but obviously the Black communities have been very hard hit. To what degree do people think that's about genetic variants, and to what degree is it a matter of social class or just of crowding and of all the people who don't have the luxury to do self-isolation and so forth?
Well, I haven't heard anything definitive about that, of course, but with most diseases, there is a genetic component in terms of susceptibility, but I have a feeling the latter factors that you mentioned are going to be much more important and already are. But, it's not just crowding, et cetera, but it's access to care,
right,
and things like that as well. in the city here in San Francisco, I mean, you're very aware, they did recently a project. This was reported on yesterday by the UC researchers. So they did a testing project in Bolinas, and they did a testing project in the Mission District of San Francisco to kind of compare and contrast. And as you know, the tests in Bolinas brought up no positives, although, again, there's questions about the accuracy of that. And in the Mission, they had quite a few, and a lot of people who were not aware and still not wearing masks and living in multifamily homes where they cannot isolate, really. So those kind of factors are huge. And I thought you were going to say, when you're talking about genetics, the virus itself, that's something I was going to mention, is mutations a big deal with these pathogens in terms of whether they are susceptible to treatments, to antiviral medications and everything. This one does seem to be, so as far as I know, mutating to change, but nothing significant yet or even expected in terms of it being no longer detectable or treatable. So most of these pathogens don't mutate to become more lethal. They actually will do less over time. But this one, they're optimistic that it's not going to change so much that they cannot, keep doing the research to control it. So that's a different issue, but genetics as well.
I want to come back to the question of whether the global South had a vote in this decision about how to approach the virus, because, for very good reasons, the developed countries and wealthy people everywhere who were able to shelter in place and do social distance and so on, made the decisions that the medical and public health communities in the developed countries have recommended. So there's no question about that. The question is, Singer's work at Princeton, the pragmatic philosopher. What is his first name? Do you remember? Peter Singer? Yeah. So he's a remarkable man, an ethicist for animals and so on. But he holds the position as a pragmatic philosopher that every life is of equal value. And so the philanthropy that he's set up in his website called The Life You Can Save focuses on Africa because his position is that you can save many more lives for the same dollar in Africa than you can in the United States or anywhere else. Well, not everybody takes that philosophical position. But if you take the position, which is not an inappropriate one, particularly because so many of us here, Robert Gold and others, have been talking about we're making, the elderly and low-income people expendable. But if we take that not at the national level, but at the global level, then authentically, what are the ethics of a decision to protect wealthier countries and wealthier people at the price of closing down the global economy, which is simply going to cause hundreds of millions of people to starve? And I haven't seen that covered very well. And I'm just curious, you are an ethicist. So how do you think about that, not only with respect to the United States, where it's more compassable, but with respect to how, when history looks at this, we will see the ethics of that choice?
Well, unfortunately, ethicists are known for raising lots of questions without answers. But,
right.
What I don't think that most of the nations, obviously it's the impact of the shutdowns in the bigger Western or the developed nations is huge, and it impacts everything worldwide. Right. But a lot of the nations are not being told what they have to do. They are making their own decisions, and so you see places where they have like Bolsonaro in Brazil and Duterte in the Philippines. They're saying no, we're not going to do this, and we'll see what the impact of that is. Really, these are people that are similar to our own current leader in some ways in terms of the distrust of expertise and being told what to do. So we're setting the example, not telling them what they have to do. But again, you're right. The shutting down of the major industrial nations to some degree has an impact worldwide. I don't have an answer for that. I really don't. My hope is that the temporary shutdown would interrupt the explosion of the pathogen, and then you bring it back gradually. I think that's what we're trying to do.
Right, but I mean, just pursuing this a little bit, because I just think it's so fundamental. If 70% of the world population is going to get it anyway, right? Something like that. Who knows? But some number, that's the number. And that may or may not confer herd immunity, but as we've said, it's likely to become endemic.
Right.
Then the argument for social isolation and so forth is a flattening the curve argument. And so the deep question for me is, yes, we flatten the curve, and that's invaluable to all of those who were able to stay alive, and maybe they will get vaccines or better treatments. But it's not going to make the virus go away. So to me, and again, I don't have an answer to this either, the Global South issue is just a really deep ethical challenge to the whole thing.
Well, it's true. And a lot of it is about protecting the most vulnerable in whatever ways we can.
Right.
We mentioned that it tends to be for older people, but one of the misperceptions that came out early is that younger people and even children were not impacted, but that's turning out to not be true.
Not to be true.
Less vulnerable than older people, but not true. And even infants now here at San Francisco General, they're getting some new reports on all kinds of new symptoms and pathologies related to this virus, which attacks the whole body. So, yeah, I don't have an answer for that. But I think one thing you wanted to talk about, Michael, too, was we're talking about the value of a life. And so in these calculations, our nation and economists and politicians for many years have struggled to put dollar values on lives, and it's fluctuated widely through time of what is a human life worth, because they're trying to measure the cost benefit of any policy, whether it's healthcare or something else. But the tacit recognition there is that some people are going to be sacrificed in some ways. So there we are. But one of the things that you and I had talked about a fair amount early on, bring it to a little more micro level in the hospital, is what do you do when you don't have the resources to save everybody? And the initial response on the need on this was ventilators in particular, getting people into the ICUs. Are there going to be enough ventilators, and how do you make sure there are enough? But the kind of second thought on that was, wait a minute, should everybody be put on a ventilator? This gets into the medical ethics side of things. Is that the best response to this? Now, if you talk to older docs about vents where you have a tube in your throat, they've called it biting plastic. And if the surveys of medical people on a number of these kind of topics through the years been remarkable in showing that most clinicians are much less likely to want a lot of these kind of interventions than the general public, because they know what it's like and how successful it is or is not. So one of the first efforts that started in January was we were working on a policy through Sutter Health, California Pacific, for the state on rationing of ventilators. And there's been a lot of commentary about this, is how do you choose who gets them or who doesn't? And many of these policies have been developed and implemented in various places, but they involved making tough decisions based on based on how likely the person was to survive and be weaned off of a ventilator, but also things like their age. So let's say you have a full ventilator unit and you've got two people who are needing them, and one is a 35-year-old mother of two, a teacher or something, and one's 75 and not likely to survive. What do you do? And clinicians themselves have never wanted to make these kinds of decisions. I'll just say that most of the policies recommend a team of people to recommend to the docs, as we do with ethics consults already. But really what this has brought up for a lot of us is the need that we've talked about for many years is many more people need to specify what they do or do not want towards the end of life. Advanced directives, healthcare directives in particular. You can only really do that if you have a good picture on what these interventions really do. And the evidence is that ventilators are a lot less effective in terms of getting people off of them. And even if you do successfully wean somebody off of a ventilator, you often have a lot of problems afterwards relating to having been on that. So I think maybe one of the good things that will come out of this is that we might get a lot more attention towards people really looking at this and documenting what their wishes are. Because most people, if you really show them what it means, would say, I don't want that.
That's right. Well, you and I have been in deep conversation about this. I just want to say your cat made a second appearance in the window, and somebody said on Rachel Reman's conversation earlier, it's not a webinar until the cat shows up. Yeah. So it's a webinar. The cat has showed up.
That's Charlie.
Joyce posted we're getting a lot of good posts, but an article by Peter Singer, who we were just talking about, when will lockdowns be worse than COVID-19? So I can't pull that up without disturbing, but I'll look at it later because we will distribute the chat to everybody who was on the call.
That is the big question, cost benefit.
Exactly. But coming back to ventilators, in a smaller group that you or I are on, I raised the report out of New York that 80% of the people on ventilators didn't make it. And then we got some feedback from people in San Francisco and actually up in Vancouver saying, I think we've learned a lot and the numbers look much better. But then, as you point out, a lot of clinicians, I mean, it's heavy duty. You get sedated first, and then, you're on this thing. And if the probability is fairly high that you're not going to live or going to have heavy duty, complications later on, as you point out, a lot of clinicians wouldn't want it. And so what I've said to you and others is that I have three questions about this. The first one we've addressed, which is the question of the ethics of the close down that Peter Singer apparently addresses in that article. The second one is one we haven't mentioned yet, which is that the mainstream people do not talk about what integrative health promotion can mean in order to increase internal resilience. And we have a earlier conversation with Dr. Cynthia Lee, who's an expert on that. And also on the Commonweal webpage, Kira can post it, we have a whole collection of the places where serious people are indicating that intensive health promotion supplements, better sleep, and the like increase immune resilience and may, number one, make it more likely that you don't get it, and number two, if you get it, make it more likely that it won't be severe. So first is the ethics for the Global South. Second is intensive health promotion. And the third, which we've just been discussing now, is how many clinicians, physicians wouldn't choose this for themselves. And so from my point of view, there's a huge issue about the denial of effective access to end of life, to humane, compassionate end of life care. If you can't get yourself to a hospital, or if you don't want to go to a hospital because you'd prefer to do this at home and take your chances and die in a place and in a way that is of your choosing. And in that instance, we talked about the compassion and care legislation, which is a wonderful, or at least controversial, but still wonderful piece of work, but it's way too slow for a virus that moves like this. We talked about hospice being able to get you medicines really quickly, and some good hospices can do that, but it's still a challenge. We've talked about going to the hospital and getting not ventilation, but compassionate care. And then I've raised the question of the ethics and trade-offs involved in just denying people in general access to compassionate ways to end their life under extreme circumstances. So anyway, those are, to me, the set of issues that this conversation and this whole set of questions has raised for me.
Well, I was going to mention Cynthia Lee's talk that you did with her just last week too.
Right.
It's really great, and she actually has a document online that is the kind of guidelines for what she looks at. And this is evidence-based to the highest extent possible. So commend that to people in terms of just
that's
your own.
CynthiaLeeMD.com, and then
Right.
you click on her publications, and you'll get a really nice ebook that talks about how you can protect yourself. Yeah.
And then, segueing into the, basically it's the choice and dying issue you're talking about in a sense of when you're not going to recover and you're trying to avoid needless suffering. And it's not a question of, years, but probably shorter time. Do you get access to whatever means you need? I think, as you know, some of the other people here know, I was steeped in this back in the beginning of the AIDS epidemic. Again, there was no good treatment. There were a lot of patients who were very clear that they did not want to suffer needlessly and were trying to find ways to get access to basically physician-assisted dying or doing it themselves. I was involved in this for 20-something years. In California, the State Medical Association was the block to legalizing it here. The ethics on this go back to Hippocrates, the Hippocratic Oath, which actually hardly anybody takes anymore. They take updated versions of that, partly due to this issue. But the Hippocratic Oath said, "Thou shalt not ever help a patient die ahead of his time," basically. A lot of question about where that came from, but it has maintained itself all the way up to now. The AMA says the same thing. The CMA here in California, the largest state medical association, adhered to that as well and would block any effort, whether legislative or initiative, to change the law to make it permissive. So this is an example of how physicians felt different. 31 years ago, I published the first ever survey of American physicians on this topic. And lo and behold, it said that about 2/3 of them thought this is sometimes an ethical thing to do and should be available. It shocked the profession. And the surveys that followed that over many years showed very similar results, fairly consistent, with tens of thousands of people surveyed. And then Oregon and Washington legalized it ahead of California. And we saw that all of the great fears about this becoming some sort of slaughterhouse or something were just not true. And in fact, in where it was examined, legalizing this focused more attention on end-of-life care in general and improved it by some measures as well. So, 4 years ago now, we finally got it through and had it legalized here in California. And I can actually post later the new issue of the Medical Society Journal that I edit has the reports from the first ever clinical conference on assisted dying, which took place in February and over in Berkeley, UC Berkeley. Sold out, 300 people, and was just an amazingly inspirational and really historic meeting because it would have been an illegal meeting just a few years back because it was talked about how to actually do this. So the access to that is improving, but what you're raising, Michael, is the issue is in order to get that passed anywhere, you need an extreme amount of safeguards, as they're called. Second opinions, waiting periods, things like that. And for a disease like this one, where it comes on quickly, you're not going to have the luxury of that time. On the other side of that, too, the first screen for anybody to do this is a lethal diagnosis, a diagnosis that you're, as with hospice care, that you're not going to survive for 6 months. So that rules out often the people with longer-term syndromes like MS or ALS who are not necessarily going to die, but are going to be in a terrible state. So there's trade-offs on this too. Some of those were political calculations. You had to have, we wouldn't have gotten it passed without all of those safeguards in there. But what you're raising is the issue of individual freedom and agency where you can do what you want, and we have a societal control over the medications, or a lot of them, that are best for this. So what can you do in the absence of being able to fulfill the criteria for that law? Now, a lot of people do take this into their own hands in different ways, sometimes tragic ways, because guns and things like that are just not the way that anybody would choose to go out, given any other alternative. There are underground guidance and sources of medications for some of these drugs, but again, you really don't want to botch it, because you can end up in a worse state, in a comatose state. So it's a tough one.
It is a tough one. I've been looking into it, and one of the languages that they use, which I don't like particularly, is rational suicide. And there are philosophers who take, who actually have spent their life or thinking about it. I don't like the term, but I prefer a term like self-deliverance myself. But I know for myself,
I can on that. There was, when I was first working on this, there was a paper in JAMA 100 plus years ago, 1890, which called it the obstetrics of the soul. So
right.
That's self-deliverance. Yeah.
Right. And James Hillman, actually, the great archetypal psychologist, wrote a remarkable essay on suicide in which he said all of our work is to prevent it, but sometimes it's what the soul needs. And so, it's just an interesting question. Our whole, I haven't done this review, and I know that many religions and philosophies hold the sacredness of life as something, that self-deliverance is just against what we should do spiritually and in every other way. But I wonder if one were to survey all the cultures of the world, in what cultures that holds true and in what cultures it doesn't. Because it does seem to me, having spent the last 35 years running retreats for cancer patients at Commonwealth, something like 220 retreats, week-long retreats, how many of those patients have gotten stashes of the meds they need to take themselves out because they don't want to either trust somebody else to make that decision for them, or there was a wonderful article, I think, in the New England Journal of Medicine, where a physician argued for compassion in dying, for helping patients die, precisely on the grounds that advances in medicine had enabled people to live far longer than they had before. As a result, they might die more difficult deaths. So he was arguing that there was a medical ethical, thing for this. So
that's been one of the primary arguments a long time. And so, right. If the initial credo is do no harm, and the argument is, well, we're actually doing a lot of these patients more harm by denying this to them.
Exactly. Jeff John Rand just wrote, "You lay it out nicely, Michael. Steve and Cynthia are our new doctors. They have so much to teach us. They are beginning to bring the mythopoetic into medicine." So, I don't begin to believe that anybody else should think what I think. And I also don't think that my thoughts are necessarily any kind of good model for social policy. I don't believe I know enough. But I do know that for myself, I know, and we've had this conversation, that I am very sure that I would not choose ventilation. And I am also hopeful that the hospices in Marin could get me what I need within 12 hours or so. But I would prefer to have my own ability and not rely on somebody else to make that decision for myself. And to me, that goes back to John Stuart Mill and one of the most fundamental principles of English medical ethics and jurisprudence, which is our right to decide for ourselves what we do with our own bodies. And to me, that's as you pointed out in our conversation, that's a libertarian point of view. But I think that's a really strong argument. And for me, I think that any law or rule that goes against that, there's a high burden of proof. And where I think it makes sense is if doing with our own bodies harms other people, then I think it can be argued. But if it does not harm other people, I prefer to take the risks that are authentic that go with giving us that power to the risks that go with withholding it from us.
Well, it's a very similar argument that is made for liberalization of drug laws as well.
Exactly.
Cost-benefit analysis.
Yeah.
But let me say something that I think I've always been fascinated by in these debates about the right to die, is that what we're talking about is giving people agency, giving them the option to do this. And the experience to date in places that have done it is that offering this to people and making it available to them, and this has been my experience too with a lot of people, is saying, okay, either here it is or I'll make it available to you when the time comes, is the primary goal of what they want. They want the knowledge that they'll have this. And a very high percentage, and in fact, maybe the majority in a lot of places, don't actually do it when the time
They don't
comes.
use it, but it gave them comfort.
They want that option, that power, that issue of control. So the biggest surveys that I've seen of people's fears and concerns about end of life, we always thought it was pain, that the people were afraid of pain. No, they were afraid of lack of control at the end, of becoming, just hooked up to machines, et cetera, and not having any control and just being in limbo. So you can never do a research study on this in a real way, but I'm convinced that legalizing this for people, making it available, results in longer life and in a larger N number of years of humans living, because they don't take the preemptive strike ahead of time. And if you look back to the Jack Kevorkian years, he was the figurehead in the 90s that really crusaded on this. He was a crazy and spooky guy who reminded me of Hannibal Lecter in Silence of the Lambs, actually. But he did put it on the front page of papers, which is what he wanted to do. But he was taking people who were afraid of the distant future. Somebody with an early Alzheimer's diagnosis who was so terrified of that they would go to him and, be put out of life in the back of his Volkswagen van. It was an illustration of people's fears about this. But what we see in hospice care as well, that if people are well taken care of, so I'm very active physically, always have been, and I used to think, man, if I lost a leg, I'd want to die, et cetera. People move those criteria back. Hospice patients will say, if I become incontinent, I want to die. If I become blind, which was common due to CMV, retinitis, and AIDS patients, I want to die. But if they get compassionate care, they move that back and say, I can live with this. But the big variable there is that they're being well taken care of, and not everybody is. But I found this argument among the decision makers and physicians that we're actually giving people power over their own lives and will probably extend their lives. Most people said, yeah, that is what seems to happen, because this was privately going on. That was the other thing, kind of like with drug abuse as well, or use. It was privately happening anyway, using, mostly opioids and so forth. But people just didn't want to talk about it publicly. But people would say, I'll help you if it comes to that. And it usually wouldn't come to that. The person would die anyway, but they would feel much more secure about it in some way.
Well, it's a profound issue, and there are casualties either way. If you do give people more agency with respect to access, that means that there will be people who take their lives for reasons we don't approve of, because they were early onset Alzheimer's and were afraid of the future or whatever. So, because they're deeply depressed. To me, the most scary part of it is when young people with their lives in front of them who've just had a tragic love affair or something and want to take themselves out. And so there are endless casualties either way. So it's a very profound question. I want to shift us. A number of our colleagues, Catherine Dodd says, going back to COVID, the other key issue is the racial inequities and outcomes. Many people of color are more likely to have comorbidities because of their generational exposure to environmental toxins, which result in diabetes, hypertension, pulmonary disorders. They are environmental diseases exacerbated by behavior, but environmental. And I would add low-income white people. They have exactly the same comorbidities. So I would say it's true of everyone. But then we also had someone say, what about COVID and climate change? And then our friend and colleague, Marion Weber, raised a question which a lot of people are raising in the CHE EMF listserv about the relationship of COVID to the electromagnetic atmosphere and the 5G. And I want to say, and then my wife, Cheryl Patton, who does a lot of work on toxic chemicals specifically, has pointed out that PFAS chemicals reduce, which are extremely widespread, reduce immune response. So we know there are good studies showing that air pollution is a significant contributor to worse outcomes. So we have climate change, we have air pollution, we have specific chemicals. We have the question of how shifting the whole electromagnetic environment affects immune function in animal experiments as well as in human exposures. How do you respond to these wide range of environmental contributors?
Well, we started with disparities, and so there's a huge constellation of factors that contribute to the disproportionate impact of any health issue in poorer populations. I mean, one that wasn't mentioned is just smoking use in history, which in this case seems to be pretty crucial because COVID is first attacks and mostly attacks the lungs. And so people who are smoking anything, really, I mean, I've had to have discussions with the medical marijuana people saying, you shouldn't be smoking anything at this point where you're at risk of this infection because it does compromise your lungs. So if you have to do it in a different route. But tobacco has been concentrated now in the lower income communities, lower socioeconomic states. No, I mean, that's the big issue is that the impact of any of these, of a new infection, almost always disproportionately impacts people who are more vulnerable for socioeconomic reasons. Diabetes, as was mentioned, Catherine mentioned. By the way, Catherine Dodd is a nurse and a longtime friend and a healthcare guru. She knows what she's speaking of. These seem to be things that make people more vulnerable to COVID as well. I do not know about 5G, really. I know that COVID is spreading lots of places, particularly that don't have it. So I don't think it's a primary contributor, but whether it could increase vulnerability, I don't know. It's possible. So
I think the stronger argument would be an argument that the enormous man-made shift in electromagnetic fields actually, there are cases where electromagnetic fields can be used beneficially for health. But this widespread shift in exposure is, I think, very problematic. And I think that while the science on it is behind the science on chemicals, I think it will turn out to be another major contributor to human health outcome.
Well, it brings up one of our core principles that we've talked about for many years with Che and et cetera, in environmental health is the precautionary principle. Whereas
Right.
If you don't really know yet, but you have a strong suspicion that something is a contributor, including in particular chemicals, you try to do what you can to minimize that while the science advances. But it's otherwise known as the better safe than sorry contributor, which in a way could bring us back to this whole discussion about the shutdown and et cetera. That is the principle that the healthcare people are using, is better safe than sorry. We can ease off on this once we flatten the curve, and that's what they're trying to do. Yeah. So it's both a chemical and a socio-economic principle, really.
I want to bring us to a subject you and I have talked a lot about, which is the relationship of COVID to what we call the global challenge or the global problematique or the human dilemma. And an easy reference for those of you who want to go to it is resilienceproject.ngo. Maybe, Kira, you could put that up as a link. But as you know, Steve, we've been looking, others have been looking at the fact that COVID and the global crash aren't just, in our view, a one-off phenomenon, that what they are is a poster child for the interaction of several dozen global stressors, and that these global stressors are creating more and more frequent future shocks of increasing intensity. And that rather than just taking this issue in isolation, that, we just hold it off for a few years, we get vaccines and better treatments, the economy will recover and we'll go back to normal, that seems really unlikely. And that where the science is headed in major ways is that we are going into an evolutionary bottleneck where we know for a fact that only a portion of biodiversity will come out of the bottleneck. And the question of what kind of humanity will come through the bottleneck is a fundamental question. So there are 4 webinars that we've done on this that you can find at resilienceproject.ngo, and we are, as we speak, migrating them over to the new school, so you can find them there as well. But we just did one with Thomas Homer Dixon, and what he talked about was how do those of us who really look at and understand the global challenge, these interacting several dozen stressors, and the clear evidence that we're moving into an evolutionary bottleneck, how do we reconcile that with holding hope for ourselves and what we tell our children about what is going on? And to me, that's one of the most fundamental questions. And it comes up now because people are terrified of COVID and the global crash. But it seems to me the deeper question is, as these future shocks continue, and as Thomas Homer Dixon pointed out, that the evidence on global surveys of attitudes and moods is that people's views of the future have gone way down globally. So how do we hold these realities, I would call them, and hold hope and know what to tell our children?
Good questions.
Good question.
Well, yeah. I mean, you and I have talked about this a lot. So that, there's a list of the most likely threats and factors to the human future. And a pandemic is only one of them, climate, et cetera, et cetera. And I wrestled with this a lot. I mean, personally, I wrestled with this at a young age to the point where I decided, and I was too steeped in apocalyptic thinking perhaps, but I decided not to have children. And a big part of it was that reason. And so I'm, on the other hand, I've just now in my extended family, 2 babies were born just last week. And I really wonder, I talk with some of the younger people I know, what do you think about the future? And so it takes a great leap of faith and hope, I think, to reproduce in this time. And that's not something you want to discourage. I think, though, it has to be an informed decision. What do you want for this new child? I think the future is daunting. We're going to go through a very difficult period, or at least the world is, over the next century or whatever period of time you want to take. The next 6 months, I think somebody asked on air, what's the next 6 months for COVID? I think we've talked about that. We're going to have a big experiment of reopening various places. Some of the countries that have reopened are already shutting back down because they see a surge immediately. Smaller places like Lebanon, example, have already said, oh, wait a minute, oops. So we could have a replay of the pandemic of influenza 100 years ago and start all over again. But that's just one thing. The bigger picture is climate, which wasn't even really a big factor in the decision-making for people, 30, 40 years ago about whether to have kids. It wasn't brought up yet so much. It was overpopulation, pollution, war, etc. So thinking about this in a rational way as much as possible and acting on it in some ways is very important. I mean, the other thing that I was going to say about contributions, whether it's, giving blood or something like that, personally, is it's more important than ever to support the people who are really working on this, the organizations, even if you don't think that they're, 100% great, whether it's, you name them, Sierra Club, Greenpeace, et cetera, et cetera. These are the kind of bodhisattva warriors of our time that have made their careers their mission, where they probably could have done something else with more reward, at least materially, have made this, their mission to try to mitigate and maybe even redirect our future in some ways.
Yeah, I agree with you. They are the bodhisattva warriors. And what that brings up for me is the quote I love from Václav Havel about the difference between optimism and hope, and how optimism is the belief that things will go well, and that hope, by contrast, is a deep orientation of the human soul that can be held in the darkest of times. That's not an exact quote. The exact quote is more complex, but that's the idea. And so for me, it's not that it's easy to be optimistic about the future, but that hope is the most interesting way to live, and that courage is the most interesting way to carry hope. And that, there is going to be an enormous amount of beautiful work, of courage, of, everyday heroism. And there is a chance, as Thomas Homer Dixon puts it, and to me this is so important, there is a chance to build a better world out of this. We don't know how big that chance is, but if you look at, the cycles of breakdown and collapse, and how in periods of collapse, there's actually an opening for new positive possibility. So it seems to me it's likely, almost certain, that we are in one of those periods of societal and indeed global collapse, and that the courageous and hopeful thing to do is to work with all our energy for better outcomes, even in the face of how problematic it is. And to me, that's what, in some way, we can tell our children. We can say, this is really difficult, but the 14th century was really difficult, There have been other really difficult periods in human history, though not on the same global scale. So it's just my sense that that's a way to live.
Can't argue with that.
Yeah.
I agree.
Well, Steve Heilig, thank you so much for this conversation. And thanks to all of you who participated. I do want to ask you, if you like this kind of work, to consider contributing, if you haven't already, to keep these going. And we'll see you next Friday. Upcoming, we have Rachel Naomi Remen, and we have B.J. Miller. Rachel Remen is coming back, and B.J. Miller is with us for the first time. And so there, I'm just scrolling. Here we go. Rachel Remen on June 5, B.J. Miller on June 19. But every Friday, we're here at 9:00, and we hope you'll rejoin us again. Steve Heilig, thank you for friendship, partnership, and for co-hosting with me at the New School.
Thank you all very much for spending this morning there.
Yeah.
We'll see you all again, I expect.
Yeah.